Hi guys, today's our topic is classification of nerves and grading of nerve injury. Before going to the classification, we'll talk about the basic structure of the nerve. So the basic structure of the nerve, we should know the basic unit, that is the neuron. So here is the neuron with a cell body. Here is the cell body and this is the axon and this is the terminal. And the cell body will be having dendrites and this soma will be having nissl bodies or nissl granules which are rough endoplasmic reticulum concerned with protein synthesis, and it contains a nucleus, and the origin of axon from cell body is called as axon hillock and the continuation is called as initial segment. And if it is a myelinated neuron, the axon is covered by myelin sheath which is given by Schwann cell, and the unmyelinated region in between the myelin sheaths we call that as node of Ranvier, and we have a terminal which have neurotransmitter stored in that. So we already said that nissl bodies or nissl granules are nothing but they are ribosomes and modified rough endoplasmic reticulum, and they are not present in the axon. They are present in the cell body and dendrites. They are absent in axon. And the initial segment is 50 to 100 micrometers in length, and the axon is covered by myelin sheath which is given by Schwann cells in the peripheral nervous system, where one Schwann cell will be giving its myelin for one axon only, whereas in the CNS oligodendrocyte is the one which is giving the myelination. Here one oligodendrocyte can myelinate many axons, and there is a protein P0 protein which is responsible for myelination. And the node of Ranvier is 1 micrometer in length. Node of Ranvier is 1 micrometer in length, which is unmyelinated zone. And in the axoplasm, the cytoplasm of the axon, there will be transport of molecules from the cell body towards the terminal and also from the terminal towards the cell body. So we have transporters like myosin 5, kinesin and dynein, which are based on microtubule. So they are based on microtubule molecular motor. And there are two kinds of transport, rapid and slow. Rapid transport is 100 to 400 mm a day, and it can be bidirectional in both directions, that is anterograde towards the forward and retrograde towards backside. So anterograde is done by kinesin where it moves 400 mm per day, and that is towards the positive terminal. Retrograde is done by dynein. It is 200 mm per day and that is towards the negative terminal. Whereas slow transport is only anterograde. That means only towards the forward, and it is very slow, 0.1 to 2 mm in a day. In this diagram you can see that this is anterograde transport and this is retrograde. Anterograde transport is by which molecular motor? So anterograde is by kinesin, whereas retrograde is by dynein. Coming to the zones of the neuron, dendrite is called as receptor zone, and this is the zone of production of local potential, or we call that as graded potential. And axon hillock and the initial segment is the site of origin of conducted impulses. That means it is the site of generation of action potential. So in a motor neuron, the site of generation of action potential is axon hillock, whereas in a sensory neuron, it is the first node of Ranvier is the site of generation of action potential, and the axon is called as zone of all or none transmission because the action potential will be transmitted all along the length with same amplitude till it reaches the terminal. Once it reaches the terminal, it causes the release of synaptic transmitter. We call that as zone of secretion. And coming to the classification of neuron based on how many poles they have. If you see here, 1, 2, 3, 4, 5, 6, 7. So many poles are there. So we are calling that as multipolar. If you see here one pole and two poles. So we call that as bipolar neuron. And here you can see that there is only one pole. So we are calling that as unipolar. Here if you see, it is appearing like it is having two poles, but it is coming from a single one. So we call that as pseudo unipolar. Even though it is appearing as a bipolar, it is a pseudo unipolar. And unipolar neurons are present in the embryo, whereas pseudo unipolar is dorsal root ganglion. So our dorsal root ganglion, which gives one branch to the receptor and one branch to the spinal cord, is a pseudo unipolar neuron. Coming to the bipolar neurons, in the retina, in the nasal and vestibular and cochlear ganglia, all these are bipolar neurons. Multipolar neurons are nothing but the classical diagram we draw for a neuron, that is a motor neuron. That's a multipolar neuron. And based on the length of the axon, Golgi type 1, which is having long axons, almost they may extend up to 1 meter, and they are the long tracts like descending tracts and the ascending tracts. Golgi type 2, these are the short axons, having short axons, and usually they are inhibitory. And coming to the classification of nerves, there are two classifications. One is Erlanger and Gasser classification and Lloyd and Hunt numerical classification. If you see here, Lloyd and Hunt classification is only for sensory. Coming to the Erlanger's classification, it is mainly based on the diameter and the conduction velocity. So more the diameter and myelination, the conduction velocity will be more. So directly proportional to conduction velocity. And if you see here, it has basically A, B and C. C is unmyelinated and the remaining A alpha to B are myelinated. Okay, coming to the A alpha is having its connections to muscle spindle and Golgi tendon organ, and also to the extrafusal fibers. So it is both having sensory as well as motor part. Sensory part is to muscle spindle and Golgi tendon organ, and motor part is to extrafusal fibers, which causes the muscle contraction. And it has a diameter of 12 to 20. So almost 6 times. 6x is the factor. So 6x into 6 into 20, around 120 milliseconds. So 6x is the factor. So a diameter of 20 will give a 20 meters per second conduction velocity. And 1A, the Lloyd's classification, which is to the sensory. 1A is muscle spindle to the muscle spindle, and 1B is to the Golgi tendon organ. And coming to the A beta is type 2 Lloyd, and it carries touch, pressure and also proprioception from muscle spindle. A gamma is motor, that's why there is no numerical classification, and it is motor to muscle spindle. And A delta is a sensory one, it is type 3 and it carries fast pain. A delta will carry fast pain and temperature sensation. B, which is again not having any numerical classification, it is preganglionic autonomic. Whereas type C, which is unmyelinated, is type 4 and it carries slow pain and temperature. And also it is present in postganglionic autonomic neurons. So that's the Erlanger's and Lloyd's classification. And there is a classification with susceptibility to hypoxia. Hypoxia, most susceptible is type B fibers and least susceptible is C and intermediate is A. So BAC is the order. Most susceptible is to hypoxia is type B, and most susceptible to pressure is type A and less is type C. In local anesthetics, you can see here there is a C and A. So C is the most susceptible, A is the least susceptible. Pressure, PAC. So PAC, PAC. Coming to the nerve injury. Nerve injury is classified by two scientists. One is Sedans, which is having three categories: neuropraxia, axonotemesis and neurotemesis. When it's Sunderland's classification, which is having first, second, third, fourth and fifth, 5 degrees. So we'll combine them and we'll see them. So before going to the nerve injury, we should have an idea of nerve structure. So these are the myelinated axons. Each one is covered by endoneurium, and these axons are bundled up to form a fasciculus, and each fasciculus is covered by perineurium, and such all fascicles are combined together to form a nerve, and that is covered by epineurium. So we have three layers in a nerve: epineurium outermost, perineurium around the fascicle, endoneurium around the individual fiber. Neuropraxia, the cause is pressure and it is first degree injury. Here nothing is going to affect. Everything is intact, only the pressure creates this damage. So there are no degenerative changes and there will be recovery completely within hours to days. There is complete recovery. And coming to the axonotemesis, which is a crush injury and it is a second degree of injury. Here the myelin is disrupted, neurolemma is intact and it undergoes Wallerian degeneration, but the recovery is complete and it takes months. Whereas transection 3, 4, 5. So neurotemesis is complete transection involving the peri, epi, endo and then the whole. So third degree here endoneurium is disrupted. Fourth degree endoneurium, perineurium both are disrupted, and the fifth endo, peri, epi everything is disrupted and is complete transection, that is called as neurotemesis, and it also undergoes Wallerian degeneration and the recovery is incomplete and the recovery requires approximation of the two cuttings. So surgical intervention is required and the recovery is incomplete. So I think it's clear. In neurotemesis, if you go like this with the peri, endo. So third degree endo is involved, fourth degree peri is involved, fifth degree epi is also involved. Coming to the degeneration. So proximal segment, so if a nerve, if an axon is injured, this is the injury site, let us think that. So the changes occurs in distal, proximal as well as distal. So whatever the changes that occur in the retrograde are chromatolysis, the Nissil granules in the cell body will be lysed and the cell body appears to be swollen and the nucleus will be pushed to the periphery and there are no Nissil granules. And whatever the changes that occur in the distal segment, we call that as Wallerian degeneration. Wallerian degeneration is the degenerative changes that occur in the axon distal to the nerve injury, and it is also called as anterograde degeneration. What happens here is axon is disintegrated and the myelin is broken down, and then the phagocytes invade this empty myelin spaces and only the myelin squam cells will remain without nothing in the center. We call them as ghost tubes, and regeneration occurs if the two cut ends are approximated and less than 3 mm in distance, and the neurolemma should be intact and the nucleus in the cell body should be intact, and regeneration is more seen in peripheral nervous system because of the alignment of squam cells. Central nervous system, it is difficult because one oligodendrocyte will be myelinating many, so approximation of those segments is not possible. So here is the depiction. If it is the site of injury, whatever the changes that occur here is called as Wallerian degeneration, and this is called ghost tubes. And the regeneration, the axon is sprouting, and the one axon will enter into the ghost tubes with the help of neurotrophins. Neurotrophins are the growth factors that are produced by the squam cells and the glial cells, which attract that sprouts into the ghost tubes, and again the axon grows in the myelin sheath, and you can see that reappearance of Nissil granules occurs, and the swollen cell body is again bring back to the normal, and the eccentric nucleus comes to the center.